So I guess the question you may have is, why is a cardiologist presenting at this meeting? Particularly, I've done no research in communication as yet. And I guess the first thing is the persuasive guy. You ask and I can say no. So I'm here there because of that. And I really thank God for thinking that I would be able to say something interesting that would help with your conference. In fact, what I'm doing today is flipping the room, so to speak, because I'm coming with some problems as a person who has no deep knowledge in semantics or the way we use language, and asking for you to hear what my world is at the moment in terms of the challenges, and potentially what the solutions from your perspective are. So the title of the presentation of Communicating the Complexity of Healthcare could easily be, go to the next slide, Communicating in Healthcare, which is complex. We okay?
No. Last speaker, I'm sorry. I don't feel welcome here. I feel I do apologize. I'm not part of this community at all. You know, even though I've worked for healthcare institutions for 30 years for nothing.
I'm sorry, that was my fault. I didn't see that there was a question. So thank you, Di. Sorry to.
That's okay. I feel sad. Sorry for that.
That was fantastic.
Yeah. I can see his hand up on. Next slide. I control it from here.
I don't think so.
Are we okay? Okay. So more than half the time remaining, I'll be asking you for some suggestions. But I'm going to cover some of the issues that I'm facing in healthcare. One of them is the issue about complexity. Yeah, thanks, Susan. It's unfortunate. I can't weave it into our discussion, but yeah. And I'll show you some things about complex adaptive systems and these things called fractals and system dynamics and archetypes, but very limited. I'm not going to go deep into that. But really, they are the issues underlying what we call the wicked problems in healthcare. And I'm going to show a little bit about my observations about what's missing when it comes to how we use language. And I would love some insights as to your thoughts as to how to get around some of the issues that I'm facing and the role of language. And I was really fascinated by Elena's presentation because it gave me some insights already. So thank you. I don't know whether people have seen this Cynefin framework for complexity, but it's got four quadrants. Chaos on the bottom left, complex, complicated, and simple. And essentially, we think of the healthcare system as a complex system, but in fact, most of the time it's chaos. And primarily because for complexity, you do need connections. You need connections to be able to move in an adaptive way where the phenomenon of self-regulation and self-organization and emergence occurs. And we don't tend to have that in most of the situations that we see in healthcare. It's chaos, it's not even connected. But nonetheless, let's go on the theme that we are as humans complex. We work in a complex adaptive system in healthcare. And ideally, with these systems, we tend to say we have shared goals. But in fact, that's a huge assumption. Often we don't have shared goals. And often, as I said, there are no connections that make us a complex adaptive system. and there are no rules for which that system is meant to work. And that's important for a complex adaptive system. So that's the background where I'm talking about, really. It's more like chaos, but in fact, it could be a complex adaptive system where these good things can emerge from our discussions to help with patient care and improved healthcare systems. This will give you an idea of hospitals as a complex adaptive system. And this is an attempt to look at priority settings at the hospital level. It's from, I think, one of the Eastern European countries. But their comment was intervening in a complex adaptive system requires fostering productive emergence, not simple mechanistic solutions. And what I see often in our discussions when it comes to policy at the level of the federal and state territory is it's very mechanistic. It's not where we should be, where we think about complexity. The other phenomenon that I'd like you to be aware of when we talk about language is this concept of fractal, where you have these repeated patterns that scale up and down. No matter what, you'll see this pattern occur. Okay, thank you. And I'd like to just concentrate on one pattern, one archetype. And this is an archetype that we use in healthcare systems to be able to make changes to services, changes to policy, changes to regulation. And it's this archetype that's termed fixes that fail. And it's also known as the archetype of oiling the squeaky wheel. So the thing that creates the most noise will be addressed first. Now, if you look at the left-hand panel, what I want to show you is the dynamic. So this is the system dynamic of this archetype of fixes that fail. You have two pathways that you can follow. One is a short pathway, one is a delayed pathway. You have a problem, you create a fix, that then helps the problem. So you have a problem that then stimulates a fix that then works against the problem. And that's you want to have those types of problems because it balances and potentially reverses that problem dynamic. But often what happens with these fixes that fail is that you have a fix that after a while, after some delay, has an unintended consequence. And often that unintended consequence works against the fundamental solution. So the short-term solution is working against the long-term solution, which then makes that problem worse. And in terms of the dynamics of this, what you'll see is that the problem will become less of a problem. And then over time, it either goes back to baseline or it becomes worse. And sometimes much, much worse. I'll give you a few examples so that it can frame the conversation. Patients living with chronic diseases. What's happening at the moment is that around the country, emergency departments are being inundated. What happens is you make the emergency departments bigger, more funding. And what happens after a period of 6 months, that improvement in the emergency department is inundated by the increased numbers. And the problem becomes worse. And we've mapped that. I haven't shown you those figures, but we've mapped that. Every time a policy change to increase funding to the emergency department occurs, it draws away from the fundamental problem, which is what's happening in GP-led primary care. And that dynamic is just becoming worse and worse in so many ways. That's one example. Another example. What about funding for healthcare or workforce training? Well, in terms of the funding for healthcare, federal government funds the primary care. The states fund hospitals. There's a cost shifting that occurs. And unfortunately, that dynamic has then caused problems which are long-term structural problems, which then makes the problem worse every time we distribute funds every year. In terms of workforce education, what happens? our healthcare workforce gets educated in silos. When we come out on the other side of that education, what do we think? We think in silos. There's no transprofessional, well, at least at a level that currently exists, that is actually working against that. Then our colleges and our various professional organisations continue to make those silos worse, those problems worse. But instead, we should be looking at integrated care and also integrating our healthcare workforce so that you can work at the top of your scope of practice and not be worried about someone else taking your turn, which is what we see every day. So I've got some living proof. In the last year, I've been involved with all of these things in terms of the National Disability Insurance Scheme, the aged care improvements, strengthening Medicare, hospital management decisions, and regulatory and accreditation bodies with AMC and things like MSAC. And I see this dynamic of fixes that fail pop its head up every single time. Now, what does that have to do with language? So what I also see is this pattern, and I'm not sure whether, have people seen this from Otto Schama? Okay, let me spend a minute or two on this. This is called Theory U. And it's a really very nice framework that I see explaining what, when I go to the meetings, what I see the stakeholders doing. On the left-hand side, as an example of what I call tribal gathering. You've got the tribes of patients and consumers. You've got the carers, the healthcare providers, the administrators, the policymakers, the politicians, the media, the community members. They may not be there in one arena, but they're there in various permutations and various arenas. And they come in, and you could almost tell which one's which from the way in which they come into the room with their downloading past patterns. So this U starts off with that downloading past patterns. It then travels through three distinct, I can see it almost happening, stages of the discussion, if it gets to those deeper stages. And what we are trying to get to is a moment where we can actually understand each other and to understand what our role is to be able to help with the situation. So I'm talking mostly with change management and policy reform. The first stage is what I would call the voice of judgment. And I'm sure you've heard people say, well, you know, you've got me on that. They wait until you say something that resonates with them, and suddenly they're away. Before then, they're listening for that. Until then, they are thinking about what they want to say. So that's the first stage, that voice of judgment. And what's required really is that you suspend your judgment and you open your mind and you're ready for other people's world. There is another world that's not yours, and you need to be open to that. The next stage is the voice of, I guess, cynicism, you could say, where suddenly you're listening to what people say, and then suddenly you will say something along the lines of, but why would this change? Why would what you're proposing change things? And what's required there is this, what's called sensing from the field, where you really do need to open your heart to think empathetically. So that's about increasing your empathy for other people's situations and their views, and being less cynical. The last one is, once you get through that, if you ever get through that in a meeting, is this voice of fear. If you're right in what you say, what does that mean for me? What am I going to miss out in a zero-sum game? And so really only then, and I see this with design efforts where you're actually talking about design theory, we don't even get to this presence in moment. We're stuck up here often, or we sometimes go here and people then worry and they don't really want to go to the next stage. So my questions to you really are, with your questions to me, potentially, what is the role of language with these discussions, where we can actually get through those stages, which I see all the time, with a dynamic that I see all the time. What are the conceptual frameworks? And Elena, you gave me some, at least with your discussion, I have some insights there. Are there other conceptual frameworks? And how can we implement this to be able to nudge us through those stages, which sometimes I just see we just don't get to the next stage. So happy for your thoughts.
Walter.